This is a 55-year-old man for a subacromial decompression on his right shoulder. He's had symptoms for about 2 years. As you saw, palpating the labrum, there's some calcific deposits which may represent a previous intra-articular steroid injection. That's the middle glenohumeral ligament overlying the subscapularis, which looks normal. Then palpating the subscapularis and its insertion over the humeral head. There's some fraying of the edges of the labrum, but it's still very firmly attached into the inferior gutter, and then the back of the humeral head. Not really expecting to find anything here. And then bringing the biceps tendon putting it into the glenohumeral joint to look for any tendinopathy or tears. Palpating the rotator cuff, which looks pretty normal. Now introducing a needle in the subacromial space to get the portal correct, and it's very important that one does that. Once this is established, a radiofrequency wand is introduced, a probe is introduced into the space. You can see there's typical scuffing of the bursal surface of the rotator cuff, though there is no full thickness tear. There's significant signs of impingement. You can see the bursa overlying the tendon. That's the bursa. And that's the CA ligament. Once this is done, a radiofrequency probe is introduced. Initially, the anterolateral corner is cleared of the CA or the coracoacromial ligament. This allows identification of a bony landmark, which is then followed both laterally and anteriorly. That's the anterolateral corner now coming into picture. One has to go deep up to into the deltoid till you see the muscle fibers, not the silver shiny stuff of the CA ligament. So that's how far one needs to go. And once that is done, coming on laterally initially to clear the periosteal of the undersurface of the acromion, releasing the periosteum from the undersurface of the acromion, coming right up to the middle to posterior 1/3 of the acromion to take away all the thickened bursa. The radiofrequency wand is used in short bursts so as to avoid any overheating. You can use a soft tissue resector. So I find once that has been cleared, I'm going on to the AC joint, clearing the undersurface of the lateral end of the clavicle. You can see it's just coming into picture now. And then we carry on till the lateral end of the clavicle is identified, removing any bursal tissue that may come in between. As can be the case, clearing the bursa from the top of the rotator cuff. right up to the muscular tendinous junction. You can see the muscle now appearing in the background. Once this is all cleared, the next step is to get an acromionizer, which is a 5.5 to 6 millimeter burr, and mark out the amount of bone that has to be trimmed. This certainly helps in the initial learning stages. Try and keep to that line. Often the temptation, or accidentally, the line can be moved further medial, which could mean resecting too much of the acromion. Once this is resected, then the burr is then moved horizontally to start to thin out the remainder of the acromion. The main culprit in impingement is obviously the anterior edge, but thinning this acromion does help to provide more space for the rotator cuff to glide easily and help improvement in the symptoms. Once this is cleared, the next step is to look for any enlargement of the lateral end of clavicle, which often is the case, and in that scenario one can trim it, otherwise the decompression looks finished here. Thank you.